Behind the Knife, the surgery podcast. Relevant and engaging content designed to help you dominate the day.
Hi, everyone. Welcome back to another journal article review with your surgical oncology team. Our whole team couldn't make it today due to conflicting schedules, but we look forward to having them next time. Let's start out with some quick introductions. I'm Joe Broderick. I'm a research resident at Brooke Army Medical Center.
I'm Lakenheath. I'm also a research resident at Brooke Army Medical Center.
I'm Tim Vreeland. I'm a surgical oncologist at Brooke Army Medical Center.
Okay, let's get started. Today we're covering two trials in melanoma, the PRADO and NADINA trial, both of which investigate the efficacy of neoadjuvant treatment in macroscopic nodal melanoma, that's stage 3B through D disease, as well as the use of response-driven treatment plans. The earlier landmark trials MSLT1 and MSLT2 were covered in a great BTK episode released in September 2022 by our UT Southwestern team. These trials established the treatment approach for intermediate thickness melanoma with a positive sentinel lymph node biopsy, showing that while these patients benefit from sentinel lymph node biopsy, they don't necessarily need a completion lymph node dissection. So with that background, Dr. Vreeland, can you start us off by setting the stage for these two trials?
Yeah, so, a lot of things have changed in melanoma because of effective medical therapy. So when I was a resident, it was like, if you had node-positive melanoma or, God forbid, metastatic melanoma, it was just a death sentence. There was really not much that could be done. And then with the introduction of ipilimumab and then other checkpoint inhibitors, the melanoma landscape just totally changed. So now when you see a patient with advanced melanoma, you say, well, hopefully you respond to immunotherapy. And if you do, then you're going to do great. And the question then becomes, and this is becoming across a number of different malignancies, is what is the role of surgery for these patients? If you have an outstanding response to immunotherapy, maybe you're cured and surgery is really not going to help you. And so that's, I think, what these trials are trying to catch up to and address is that, all of a sudden we have this miracle therapy of immunotherapy. I shouldn't use that term because it doesn't work for everybody. The question is, when it works incredibly well. And I am very loath to ever use the word cure in the world of surgical oncology, but with immunotherapy, when you respond really well, there are a subset of patients that are truly cured. And so even if you present with bulky lymph node disease, if it all gets totally wiped out with immunotherapy, then why are we operating? Are we actually helping anyone by operating? And just like with MSLT2, where we saw that sometimes less surgery doesn't actually hurt the patient, now you factor in, well, they had a great response to immunotherapy. What are we really doing by doing a lymph node dissection and potentially adding morbidity to these patients? And I think a lot of the residents probably do a lot of breast surgery, and we're going away more and more from doing axillary surgery in the world of breast. It's even more important in the world of melanoma because you're talking about groin dissections. So an axillary dissection, sure, there's some morbidity, there's some pain, there's a risk of arm swelling, but the rate of lymphedema of the lower extremity and the wound complications of a groin dissection are much, much higher. So the push to get away from dissections is even stronger in melanoma than it is in breast. And so that's kind of where we've landed on these trials of like, do we really need to do a groin dissection just because the patient presented with bulky disease if they respond to checkpoint inhibitors? And that if they respond being the key part.
Thanks, Dr. Vreeland. With that, Galen, do you think you could tell us a little bit about how checkpoint inhibitors work?
Yeah, definitely. One of the defining features of melanoma, as with many cancers, is its ability to evade the immune system. So tumor cells can do this by exploiting the immune system's natural brakes, known as immune checkpoints, which normally serve to keep T cell activation under control. By activating these checkpoints, the tumor cells can essentially turn the T cells off, preventing them from recognizing and killing the cancer cells. The two major checkpoints that we target in melanoma are CTLA-4 and PD-1 and PD-L1. Checkpoint inhibitors block these brakes, preventing the tumor from shutting down the immune system response. This allows the T cells to not only attack the tumor more effectively, but also to proliferate and amplify the overall anti-tumor response being developed. Joe, can you tell us a little about what's unique in using these drugs before surgery in the neoadjuvant setting?
Yeah, for sure. Historically, checkpoint inhibitors were given after surgery in the adjuvant setting when most of the tumor has been removed. The potential issue is that with so little tumor remaining, there's less material for the immune system to recognize and build a strong, durable T cell response to. Neoadjuvant therapy flips that model. By introducing checkpoint inhibitors while the tumor is still in place, you expose the immune system to a much larger pool of antigens. This is theorized to lead to a more robust T cell priming, greater clonal expansion, and really ultimately a stronger systemic response. The idea is that this upfront activation will shrink the tumor before surgery and it'll set them up for better long-term control of metastatic disease. So now that we have some background, let's get started with these trials. Go ahead, Galen.
Yeah, early trials prior to PRADO and NADINA suggested that neoadjuvant checkpoint inhibitors such as ipilimumab and nivolumab can induce high rates of pathologic response in patients with macroscopic nodal melanoma. So in other words, these tumors were resected after neoadjuvant therapy, and a large proportion showed minimal or no viable tumor onset pathology. So this supports that concept of keeping the tumor in place during immunotherapy and may end up generating a stronger, more effective anti-tumor response. Although these were small studies, patients with a major pathologic response also associated with markedly improved recurrence-free survival compared to the historical expectations. At the same time, other earlier phase work had explored avoiding upfront therapeutic lymph node dissections. And these studies showed that the index lymph node, the largest lymph node involved in the basin, can serve as a reliable surrogate for assessing the overall nodal pathologic response. So kind of putting it all together, there's a few questions that these trials look to answer. First, can neoadjuvant immunotherapy improve prognosis in patients with macroscopic nodal melanoma? Second, if a patient does have a strong pathologic response, is there an opportunity there to de-escalate surgery or adjuvant therapies? And then lastly, can the index lymph node reliably measure the response and guide subsequent treatment decisions? So with these questions in mind, Joe, can you get us started with talking about the PRADO trial?
Just real quick before you guys do that, hopefully you guys understand some of the kind of background of that index lymph node question, right? So in breast, we have what's called a targeted lymph node dissection where you clip the node, you do a biopsy, you clip the node up front, give them neoadjuvant, and then you take that clip node out and then a sentinel node as well. And that basically has shown that if you take those two out and they're negative, then the rest of the axilla is negative. And so there was sort of that historical context for the idea to then be pushed into melanoma. So I don't know that people would have trusted it as much if we didn't have all that history with breast.
Okay, yeah, it makes sense. Thanks, Dr. Vreeland. So let's get started with the PRADO trial. PRADO was a phase 2 trial investigating the safety and efficacy of neoadjuvant IPI and Nivo for patients with macroscopic nodal melanoma, along with the feasibility of using this index lymph node to guide the subsequent management. This builds on the OPS-NEO trial, which determined the optimal dosing and schedule for neoadjuvant IPI-NIVO, and showed that this regimen could produce a very high pathological response rate. So, Galen, can you tell us the trial design?
Yeah, definitely. So PRADO was a prospective single-arm extension cohort from that OPS-NEO trial. It included patients with resectable macroscopic nodal melanoma. All patients underwent the marking of the index lymph node at enrollment, followed by 2 cycles of IPI-NIVO with the index lymph node resection at week 6. Subsequent treatment was then determined based off of that pathologic response found in that index lymph node. So I grouped patients into one of 3 categories, either a major response, a partial response, or a non-response. Joe, can you explain these groups to us and the primary endpoints of that trial?
Sure thing. The major pathological response group, patients with 10% or less residual viable tumor on pathology, got no further treatment and just underwent surveillance. So they had no lymph node resection and they didn't receive any adjuvant therapy. The partial pathological response group, that was patients with 10 to 50% residual tumor on path, they underwent a therapeutic lymph node dissection but got no adjuvant therapy. And then the pathological non-response group, so that's patients with greater than 50% residual viable tumor, they got the full deal, a therapeutic lymph node dissection, adjuvant therapy, and even possible radiotherapy. The trial overall had 2 primary endpoints. One was the pathological response rate, and the other was 24-month recurrence-free survival.
Perfect. Thanks, Joe. So in summary, this is a response-directed de-escalation based off the tumor response we're seeing in the index lymph node. And also, we're going to investigate the safety and efficacy of neoadjuvant IPI-NIVO. So let's start working through some of the results. In the 99 patients that were enrolled, 90% were able to receive the planned 2 cycles of neoadjuvant ipi-nivo. And only 10% had received 1 cycle due to adverse events. In total, 22% of patients experienced a grade 3, grade 4 adverse event, majority being related to immune-related hepatitis or diarrhea and colitis. No treatment-related deaths were observed in the cohort.
And just a comment again on historical context there. So IPI is a CTLA-4 inhibitor, Nivo PD-1. So the IPI came out first. It was more effective than any drug had ever been in the setting of metastatic melanoma, but very toxic. And what I mean by that is that it's not that all the patients had toxicity, which is kind of what you see with chemotherapy. What you see with immunotherapy is a little bit different. It's like only some patients have toxicity, but the ones that do have a lot of toxicity. So in the initial IPI trial, there were patients that died of colitis because nobody really knew how to manage it. And so that was kind of a scary drug. Then they gave both and they found that it worked better, but there was even more toxicity. So that ipi-nivo combination had a lot of toxicity when it was first being used, it's probably 7-8 years ago. And then when the PD-1s came out as single agent, most people sort of preferred just giving that because the toxicity was a little less severe, even though people still had autoimmune toxicities, but it just wasn't quite as scary. And so then putting back the ipi-nivo together has always been like, well, we'll do that if the single agent PD-1 doesn't work. We'll add the CTLA-4, but we know that the toxicity is going to be worse. So these adverse event numbers are really pretty promising. There's only 10% had to stop. Now, granted, it's only 2 cycles, but only 10% had to stop due to adverse events and only 22% experienced a grade 3 or 4. Those numbers are significantly better than the early trials with these. And that's probably because now medical oncologists know how to recognize these and treat them very quickly. So as soon as the patient presents with some diarrhea, they start him on steroids, that kind of a thing. And so I think ipi-nivo is considered a very scary combination. This trial shows that really it's not too bad. But another very important thing is it's only 2 cycles. So it's not like neoadjuvant for breast where they get 6 months of therapy, before you go take that index. No, you're talking just 2 cycles. And again, that speaks to the biologic effect of immunotherapy. When it works, a lot of times it works right away, like 1 cycle and boom, the disease is disappearing. And it may not disappear radiographically, but the lymph node may not shrink, but all the cells inside are dead, kind of a thing. And so it's really a remarkable drug and really has changed the face of oncology in general, these immunotherapies have. So a couple of things to highlight is that it's only 2 cycles. It's very quick. They're 3-week cycles typically. So you're talking about 6 weeks of neoadjuvant therapy as opposed to 6 months. When it works really quickly. And we as a field have gotten a lot better at using them. Toxicity not too crazy in these trials.
Yeah, thanks, Dr. Vreeland. Kind of like you said, the neoadjuvant immunotherapy was really well tolerated in this trial. Now, Galen, can you tell us about the pathological response found on the index lymph node?
Yeah, so the researchers were able to demonstrate high feasibility of performing the index lymph node dissection, as 96% of patients were able to have that node retrieved. And while only 45% of them demonstrated a radiographic response, 72% had a significant pathologic response. So if we break that down a little bit more, 49% had a pathologically complete response, 12% had a near complete response, and 11% had a partial response. And then the last 21% were non-responders.
But just really remarkable. 2 cycles of therapy, half the patients complete pathologic response. You don't see that anywhere else. You don't see that ever with chemo. It's just, these are unbelievable numbers.
Yeah, even though the radiological response wasn't a reliable indicator, the almost 3/4 of patients had a pathological response, allowing de-escalation with adjuvant treatment is, like Dr. Vreeland said, truly amazing.
Exactly. And this is important as 84% of the patients that ended up undergoing a total lymph node dissection experienced surgery-related adverse events compared to the 46 that underwent the index node dissection only. So even more on patient-related outcomes, those undergoing the index lymph node dissection compared to the therapeutic lymph node dissection, which is significantly better global and physical functioning, as well as quality of life metrics at 12 weeks, with some of those improvements lasting even 2 years post-op.
Yeah, that's an important point and demonstrates how foregoing a therapeutic lymph node dissection really does make a difference for patients. Galen, what were the survival outcomes?
After a median follow-up of 28.1 months, the estimated 24-month recurrence-free survival for the entire cohort was 85%, with an event-free survival of 80%, distant metastasis-free survival of 89%, and overall survival of 95%. Let's break it down a little bit farther. So in the first group, the major pathologic responders, they did not undergo the therapeutic lymph node dissection or adjuvant therapy. Their 24 months recurrence-free survival is 93%, and their distant metastasis-free survival is 98%. In our second group, the partial pathologic responders, they underwent the therapeutic lymph node dissection but did not receive adjuvant therapy. Their 24 months recurrence-free survival was 64%, and distant metastasis-free survival was 64% as well. And then lastly, in our third group, the pathologic non-responders who underwent the escalation, therapeutic lymph node dissection, and adjuvant therapy, their 24 months recurrence-free survival was 71%, and distant metastasis-free survival was 76%. So summing it all up, those with the major pathologic response had exceptionally better outcomes, even without the therapeutic lymph node dissection or the adjuvant therapy. While those that are partial responders, they had a worse overall response with de-escalation compared to those non-responders who did undergo escalation, adjuvant therapy, and therapeutic lymph node dissection.
So yeah, I would sum that up, and I hate to say this as a surgical oncologist, but I would sum that up as surgery doesn't actually do that much, and effective medical therapy does so much, which has been a theme of my voice on this podcast for years. We love to do surgery, and it helps some, but you look at the patients who got two cycles of therapy and nothing else. And if they had a strong response, they had a 2% chance of developing metastatic disease in the next 2 years. And that's what they die of, right? That's what patients care. They want to live. They don't want to have metastatic disease. 2% chance of recurrence. Whereas if they had a partial response and got surgery, but no more medical therapy, they now had a 36% response. So that group actually did the worst, the ones that did not get additional medical therapy. And they still got the surgery that we can offer. So it's not that surgery does nothing. It helps clean up the mess, but man, effective medical therapy trumps surgery 10 times out of 10.
That makes sense, Dr. Vreeland. It's important to note some significant limitations to the study. So first, PRADO is a single-arm phase 2 trial with no randomization or control group. So all the comparisons are indirect, and these results therefore are hypothesis generating only. Sample size is small. With even smaller subgroups, only 11 patients in the partial non-responder group, for example. And another question is whether the index lymph node truly represents the pathologic response, the entire nodal basin. So the heterogeneity of the response remains a concern. For patients who did not undergo surgery, that remains unknown. And then finally, longer follow-up and follow-on trials are definitely needed.
Thanks, Galen. We should hopefully see some updated long-term results from PRADO in the near future, as well as some early findings of MSLT3, which builds off this trial and will answer these exact questions.
Perfect.
Today's episode of the Behind the Knife podcast is brought to you by our presenting sponsor, Gore Medical Products Division. When it comes to ventral hernia repair in high BMI and comorbid patients, strength matters. Gore Cinecore biomaterial is a permanent mesh that is built like a lightweight, with the strength of a heavyweight and has 0 reported mesh fractures. With a less than 1% recurrence rate in ventral hernia working group grade 1 and 2 patients and a low rate of infection, Cinecore is designed to support your complex ventral hernia repairs. Visit goremedical.com/btkpod to learn more and ask your Gore representative about sizing and availability. Gore is Cinecore biomaterial, no compromise for your high BMI and comorbid patients. Intended for U.S. audiences only, Gore is a financial sponsor of this podcast, which has been independently developed by the presenters and does not constitute medical advice from Gore. Always consult the instructions for use prior to using any medical device.
Now let's transition to our next trial, the NADINA trial. This sought to show whether or not neoadjuvant immunotherapy should be the new standard of care for macroscopic nodal melanoma. Joe, can you introduce this trial for us?
Yeah, will do. As we previously discussed earlier, phase 2 trials had suggested that neoadjuvant administration of immunotherapy improves event-free survival when compared to just adjuvant administration, with the best results seen with the combination regimen ipi-nivo, as Dr. Vreeland discussed. The NADINA trial was a multicenter international phase 3 trial that randomly assigned patients with resectable macroscopic stage 3 melanoma to receive either neoadjuvant or adjuvant immune checkpoint inhibition. So we're comparing the neoadjuvant regimen to just the adjuvant regimen. Macroscopic disease was defined as pathologically proven lymph node metastases that was palpable, positive according to PET, or measurable on imaging.
Yeah, just a comment on the macroscopic. So this again, so much of this stuff, breast cancers is so much more common, and this axillary management stuff is so applicable between the two diseases. One of the controversies in breast for a while was, are we defining a clinically positive node as that which can be felt on exam or seen on ultrasound? Because some centers were doing ultrasound on everybody, some weren't. And so now it's pushed more towards most breast surgeons are getting an axillary ultrasound anytime they're diagnosed with a breast cancer. So most breast imaging centers, if they diagnose breast cancer, they're automatically going to ultrasound the axilla. And then they may find a node that has a thickened cortex, looks abnormal, but would never be felt on exam, particularly with an obese patient. So should we be doing that with melanoma? I think is an open question right now. I lean towards yes, because now that we have something to do with that information, I want it. Right. So if you have no treatment for a node positive patient, why diagnose it? Just do the sentinel node and figure it out later. Right. But now we have meaningful treatment for these patients. So you want to know that information when you can. The question is, should we be hitting patients with a slightly thickened cortex and a needle positive lymph node with ipi-nivo? That's kind of a more subtle question. But I think knowing about these lymph nodes up front, now we can actually do something about it. So I think more places are moving towards either more PET scans or more nodal based ultrasounds up front, because the reality in America is half our patients are obese. It's really hard to feel a node sometimes in an obese patient in their groin or in their axilla. So imaging can be helpful. So I like the way they classified this. They didn't say palpable positive node. They said palpable or enlarged on imaging, because that is a much more practical definition than what often were used in the early trials in breast cancer, where they just talked about clinically positive nodes, which most people interpreted as palpable.
Perfect. Thank you, Dr. Vreeland. Joe, can you tell us about the treatment regimens?
Yeah, for sure. Patients in the neoadjuvant group received 2 cycles of ipi-nivo, followed by a therapeutic lymph node dissection, and, if applicable, resection of in-transit metastases. Patients who had a locally assessed major pathological response didn't receive any adjuvant treatment, and patients who had a partial pathological response or pathological null response received adjuvant BRAF targeted therapy for 46 weeks if their melanoma had a BRAF mutation, or received an additional 11 cycles of adjuvant nivo every 4 weeks if the melanoma was BRAF wild type. Patients in the adjuvant group underwent a therapeutic lymph node dissection in week 0, followed by 12 cycles of adjuvant nivo every 4 weeks, starting between weeks 6 and 12.
Just a quick mention for those that might be confused by the BRAF thing. We've been talking about immunotherapy, now we're throwing in BRAF. So about 60% of melanomas will be BRAF V600 mutated. Those patients will respond to other targeted therapies that, is roughly called BRAF or BRAF MEK inhibition. So for patients who don't respond to immunotherapy, for 60% of them, there is another option. So this trial is saying, listen, if you didn't respond to immunotherapy, it would be malpractice to keep you on immunotherapy if you have this other effective therapy available. So they just moved the adjuvant arm to BRAF directed therapy if patients have BRAF mutation. If they don't have a BRAF mutation, they're really stuck with immunotherapy and nothing else.
So to summarize, we have a population of macroscopic nodal melanoma patients all undergoing a therapeutic lymph node dissection that are divided into 2 arms. The neoadjuvant arm underwent response-directed systemic therapy, and the standard of care arm where all patients got upfront surgery and adjuvant systemic therapy. So Joe, can you tell us what the primary and secondary endpoints were and start off with some of the results?
Yeah, so the primary endpoint was event-free survival, defined as time from randomization to the progression to unresectable melanoma before surgery, disease recurrence, or death due to melanoma or treatment. Secondary endpoints include pathological response, safety measures, and a few others that weren't reported in this publication for reasons we'll kind of discuss later. A total of 423 patients underwent randomization. All the neoadjuvant patients started systemic therapy, with roughly 94% receiving the planned 2 cycles ipi-nivo. Therapeutic lymph node dissection was performed in about 93% of patients in the neoadjuvant group, and in the adjuvant group, 98% of patients underwent their therapeutic lymph node dissection.
Awesome. Thank you. So in our neoadjuvant arm, nearly all the patients that started ipi-nivo were able to complete it, less than 5% not proceeding to surgery, really demonstrating the feasibility of this neoadjuvant approach. Can you tell us a little bit about the efficacy of this?
Yeah, so this trial was ultimately published after the first interim analysis, given the overwhelming positive results for event-free survival. The estimated 12-month event-free survival was 83.7% in the neoadjuvant group versus 57.2% in the adjuvant group. These are truly paradigm-changing results, with only about 20% of patients experiencing an event at 12 months in the neoadjuvant group versus almost half of patients experiencing an event at 12 months in the adjuvant group. Now, Galen, can you break it down a little bit further by the pathological response?
Yeah, so in the neoadjuvant group, all patients had received at least one dose of neoadjuvant therapy to be assessed for pathologic response. So 59% had a major pathologic response, and 47.2% of total patients having a pathologically complete response, so no residual tumor. 8% of patients had a partial pathologic response, about 26% had a pathologic non-response, and then 2.4% had progression prior to surgery. So the event-free survival at 12 months was 95% for the major pathologic response, 76% for the partial pathologic response, and 57% for the non-responders.
Thanks, Galen. So almost no patients who had a major pathological response and did not undergo adjuvant therapy had an event at 12 months, versus nearly half the patients who had a pathological non-response and did receive adjuvant therapy had an event at 12 months. This really highlights how prognostic treatment response can be and how much tumor biology really matters.
Yeah, very similar to the other trial. A couple just distinctions for everybody in these trials. This was a phase 3 trial, it was larger, right? So people are going to trust the results a little bit more. The PRADO trial was a phase 2 trial, but as a surgeon and as a practitioner, I think it's a better trial. Like, that's the question I want answered, is whether or not you need a therapeutic lymph node dissection. This trial didn't answer that question. So it said, if you have a major pathologic response, you're going to do better. Okay, that's not shocking, but it does. I think what shocked people about this trial was 2 cycles of immunotherapy and that many patients, 60% roughly, had a pathologic complete response. So that was like the huge takeaway from this trial that I think was, like you said, kind of paradigm shifting. The other thing it said, which everyone kind of suspected, is that neoadjuvant immunotherapy is better. So you should give it up front, which again makes you think I should try to diagnose as advanced a stage as I can to justify neoadjuvant in some ways. Not that you want the patients to have advanced stage, but if they have a positive lymph node, you want to know about it. So make sure you're doing a thorough nodal exam and then get an ultrasound or a PET if you have a high suspicion. So, I think these 2 trials taken together, neoadjuvant is better. If they have a major pathologic response, they're just going to do way better. Not shocking, right? Then the question that MSLT, he will answer in what PRADO sort of answered, but it's only a phase 2, so it needs to be confirmed in a larger trial, is if you can do a targeted dissection a la breast cancer, right? Like, clip that node up, do a needle biopsy, leave a clip in that node, give them 2 cycles of immunotherapy, and then take that node out and see what happens. If they had a complete response, you're probably done. But I think that until that trial is done, most practitioners are probably going to keep giving some PD-1. So a lot of med oncs are going to finish the year of Nevo is kind of what they talk about, even if they had a pathological response. This data would say you probably don't even need that. The good thing is that single agent Nevo for a lot of patients is so well tolerated that it's not a huge deal, minus the financial burden potentially. And I think that most people with this data in mind, as soon as the patient has an adverse event, they stop the adjuvant therapy. They say, well, you don't really need it. Probably will get to the point where they're not getting that adjuvant therapy. But I think those are, kind of the summary take homes from these 2 trials. And I think that MSLT3 will hopefully hammer it all home if it shows similar results to PRADO.
Thanks, Dr. Vreeland. Galen, do you want to finish us up just by discussing the safety of these treatments?
Yeah, definitely. So grade 3 or higher adverse events occur in about half the patients in the neoadjuvant group and only a third of patients in the adjuvant group. Most frequent adverse event were hypothyroidism and adrenal insufficiency. And 1 patient died in the adjuvant group from pneumonitis caused by Nevo. No treatment-related deaths occurred in the neoadjuvant group.
Thanks, Galen. So while neoadjuvant therapy resulted in better event-free survival, it also had higher rates of adverse events relative to the adjuvant group, which is as to be expected, with almost half of patients having grade 3 or higher events versus a third in the adjuvant group. Now, Galen, Dr. Vreeland already kind of discussed this, but can you briefly go over some of the limitations of this trial?
Yeah, so despite the objective superiority of neoadjuvant treatment, these are 1-year results that are short-term, and additional follow-up is going to be needed. It's important to realize that the neoadjuvant arm had double the toxicity of the adjuvant therapy alone arm for grade 3 and higher adverse events. It's also worth noting that the treatment approach relies on reliable evaluation of that pathologic response by a local pathologist, which may not be available for every institution. And then finally, NADINA included therapeutic lymph node dissection for both arms in the trial, but as demonstrated in the PRADO trial, this treatment strategy is in evolution right now. So synthesizing different treatment strategies across multiple trials is an ongoing effort that needs more investigation.
Thanks, Galen. So the NADINA trial changed the treatment paradigm for macroscopic nodal melanoma, with neoadjuvant therapy suggesting superiority to adjuvant therapy alone in terms of event-free survival. For the general surgeon in the community, the takeaway is if you see a patient with macroscopic nodal melanoma, you should be thinking neoadjuvant therapy and get them to a center that can discuss the relevant benefits and downsides. These trials still leave a couple important questions left for further investigation. Can the index lymph node truly be used as a surrogate for disease burden and dictate subsequent therapy, negating the need for therapeutic lymph node dissection? And the other question is, what more can we do for patients who do not have a major pathological response, whose outcomes are kind of still wanting?
Yeah, so I think for the residents, just to put it in a clinical context, so a patient presents with clinically positive nodes. The old paradigm was like you would just immediately do a resection with a therapeutic dissection and then put them on some kind of adjuvant therapy. But the paradigm has shifted. That patient should get neoadjuvant therapy. That therapy, in the light of these trials, should probably be a short course of dual agent therapy. And then you should go take out a representative lymph node. If they have like grossly matted nodes up front, you probably could just take out that kind of, oftentimes, even if they respond, those nodes will sort of stay in a matted ball and you end up almost doing a therapeutic dissection anyway, but you try not to. If they don't, ideally, what you need to make sure of is that there's a clip in a node that you know is positive, right? So how do you do that? Up front, you get an ultrasound guided biopsy, you leave a clip. That biopsy comes back positive, great. They get 2 cycles of ipi-nivo. You then go take that node out. Now, again, this is based on phase 2 data, so the guidelines are sort of wishy-washy, haven't totally caught up, but in practice, this is kind of what I'm doing. Everybody's anticipating the MSLT3 trial. For now, standard of care is, we're in this sort of gray area, like we were with breast 5 years ago, where it's like, do you still do a therapeutic dissection because they had clinically positive nodes up front? I am of the belief that this is where we're headed. And so I talk to the patients about it. I say the guidelines don't exactly say this, but this is what I think is best. So you go take that node out. That node comes back with 0 cancer cells in it. In my opinion, they probably don't benefit from a therapeutic dissection. Again, we need that phase 3 data. They don't have a pathologic complete response. They have a partial response. This is, I think, the difficult area right now, because there is some data from other cancers that if you give them more immunotherapy, then maybe they'll continue to respond. And maybe they'll get to a more significant response with more immunotherapy. But I think the standard of care right now would be that patient needs a therapeutic dissection. And in my opinion, it should then get some more immunotherapy. If they don't respond at all to immunotherapy, then you're sort of barking up the wrong tree. Hopefully they have a BRAF mutation. You can treat them that way. There is no data to say that that patient doesn't need a therapeutic dissection, even if they respond to other targeted therapies to BRAF MEK. Part of that is the mechanism, right? So BRAF MEK, those, it's just different. Immunotherapy is different. It uses the immune system, and probably when you have a great response, that response lasts longer than anything we've ever seen with normal systemic chemo. I think BRAF MEK, it's targeted, but it's more in that kind of realm where they're going to respond, but eventually they may recur. And so maybe there's more benefit to clearing out those nodes surgically. And that's all kind of up in the air, big maybe stuff. But I think that's kind of the way I would put it in my head is give the neoadjuvant, and then if they have a pathological complete response, probably don't need anything else. If they have a partial response, nobody really knows what to do. Maybe more immunotherapy, maybe do that dissection down the road, maybe do it now. I don't think you can be faulted either way. If they don't respond at all, you got to do something different.
Thanks, Dr. Vreeland. I think that's a good ending point for today's episode. Thanks for joining us on Behind the Knife Surgical Oncology. Dominate the day.
Be sure to check out our website at www.behindtheknife.org. Download our free app available for Apple, iOS, and Android. Simply search for Behind the Knife in the App Store or Google Play to download the app. In the app, you can listen to our episodes, watch high-yield videos, and even access our premium content, including our oral board reviews and trauma video atlas. You can also follow us on Twitter at Behind the Knife and on Instagram at Behind the Knife Podcast. If you like what you hear, please be sure to leave us a review. Content produced by Behind the Knife is intended for health professionals and is for educational purposes only. We do not diagnose, treat, or offer patient-specific advice. Thank you for listening. We appreciate your support.
Until next time, dominate the day.